I just want to welcome everyone to the second IBD educational session that we have had so far in this COVID era. I think, as this is, I guess, maybe a silver lining, there are some silver linings in all of this, but I really enjoy seeing everyone on these calls and attending, and I think that people are enjoying them and getting use out of them. So thank you so much for attending. And I also really want to thank Dr. Lakatos for giving tonight's presentation on COVID and IBD, Fears, Facts, and Fiction. Dr. Peter Lakatos is Professor of Medicine and Director of the IBD Center at the MUHC. Until January 2017, he was head of the Gastroenterology, Hepatology Ward, Endoscopy Unit and Outpatient Clinic at the first Department of Medicine at a university in Budapest in Hungary. So since then he came here. In his career, he published more than 300 original papers and reviews, including 26 book chapters, and his primary research is in the epidemiology, quality of care, outcomes, research, and optimization of old and new medical therapies in IBD. So we are very much looking forward to hear what you have to say about fears, facts, and fiction in this age of COVID. So welcome and thank you.
So thank you very much. Please use mute yourself and use the chat box, or thereafter we can of course discuss. And I felt that that would be a good time. We have had enough exposure, and everyone has its own experience now with the COVID. And I'd like to give you a little bit of an update from, let's say, a specialist point of view, as well as a more general update on where we are regarding the COVID, and what we as specialists fear of, and what we do think about this pandemic. Some disclosures, most of them will be not relevant to this talk, and then a little bit of the trends where we are after let's say February, March, when we all were shocked about the lockdown, what has happened. And now that Europe reopened, but thereafter, 1 or 2 weeks, some of the countries already stepped back already. So what do we have to face, and what do we have to know about where we are? So this virus is probably not so new. Some of you might have remembered that there was this bird influenza, the SARS virus, about 15 years ago. This is called actually a SARS-CoV-2 virus, not directly related, but somewhat similar. And then there were a lot of questions around, of course, because that was coming from actually originating from a Chinese city that hosts one of the biggest and best advanced viral laboratories, whether it was engineered or it's natural, what's the course of the disease, and what do we have to know about it. I hope that I will just share you some information that some of you might not know, and that puts this question hopefully actually into the past, and you will see more that it's most probably actually a natural evolution of our environment. So this is what we have seen, and you have been all part of it. We have heard some news as of December, maybe some early November, starts from China, that we are facing something new. And they already locked down, and that was not new. That was already there for the bird influenza, some more than a half decades ago. But what has happened thereafter, that was unprecedented throughout the world. And you see that already as of mid-January, we had the World Health Organization responding, and more places started isolation and quarantine. Actually, Canada was very early on these steps, and we were again isolating as of late January, February, and the lockdown came around March. However, that's not all true, because some of the researchers, they took some samples, regular samples, as of as early as 2019 or 2018, and maybe that's a surprise. Maybe some of you would have suspected it. Actually, I read it some days ago, actually 2-3 days ago. This was published, that there were some traces of the virus already in the sewage system, at least that was found in Spain as early as early last year. So probably all what we have known about the spread of the pandemic is a little bit just after really the shocking symptomatic curve. that we have seen, but you know, there were some events ongoing already before that. And then if we go further, you see this is the global trend as of now. So this was May 11, once again. And this is now about 10 million. 10 million, this was 2 days ago. So we passed 10 million worldwide, about 500,000, so around 45% mortality worldwide. And if you look at now, then the center of the pandemic is really now US and America at the moment. China is, of course, you know, discussing about possible second wave. Canada is actually doing pretty good. I will just show you the new data. And I think, you know, all the efforts about the social distancing and isolation, they made it very, very, like, you know, valid. And now the outcomes and the new case numbers in Canada are really good. And if you look at this in numbers, then you see that all these curves below the map, they are actually coming downwards, meaning that you see that there was the peak around, like, you know, early mid-May, and now the Canadian numbers are going down, notwithstanding the fact that at the moment Canada has more than 100,000 cases. But if you look at the second half of the curves after May, this is now the June curve. The curve is 2 days ago. It was published on the web. You see that all numbers and the new case numbers are actually going downwards. So that's good news. Hopefully Canada has a good control over the cases. And this is what you see here, that the cases recovering is going up. This is good news. The total active case number decreased. So what we will discuss soon, that actually the R curve, meaning that how many patients are active compared to passing on the virus, this is below 1, which is showing a good trend with regards to control of this pandemic in Canada. If you look at once again the total case number, then you have to acknowledge that Quebec has the lead with Ontario. And again, if you look at the contact or travelers, then basically what you see there, that the majority of the cases as of after March, in April and May, they became either contacts or really the population spread. So this is Canadian patients passing on Canadian patients. This is what you see here. And the number of deaths, no surprise there either. It's following the total case number. So Quebec again, and Ontario has the lead. If you look at the case distribution, this is a little bit different than what you see in Europe. So it's quite even, a little bit more females than males, but quite even across the age groups. And the most important slide comes now with regards to the outcome. And this is actually what we have seen in the hospitals when we're working on the COVID wards, that actually patients really in the elderly stage, so 80 plus, they are the ones who are in danger. We had a little slight, imbalance between the genders, and males were more fragile as for many outcomes. But the most important take-home message, that below the age of 60, not much was happening. And above the age of 70, it started to, have this effect. And what you see, that quite a bit of the patients who died, they actually were 80 plus. So this is really affecting the elderly population worldwide as well as in Canada. So we did see this number now, and this is what we have seen also in the clinical wards when we were working with the comorbid elderly population. They were the more fragile. What were the risk factors? I just show you 2 examples. One is the Chinese study, one of the first that was published. It was again, comorbidities, that's the multi-organ failure, older age, and the higher inflammatory status. This is what you see by the D dimer. This was the, determinants of the outcome. And not much changed if you look at the other part after 6 studies and the meta-analysis that included Caucasian and European data. You see hypertension, chronic diseases of the heart, and then the lungs, diabetes, they made their tolls. So these were, the risk factors identified upon the age. And there is something else that I'd like to share. Of course, my background, I'm coming from Europe. We have a lot of vaccinations, and there was always discussion, and it's still ongoing, why some of the European countries, especially in the Eastern Bloc, they have exquisitely good patient numbers and actually not so bad, total, mortality numbers. And one of the explanations might be that the vaccinations that you overall receive in your life, they could help actually fight COVID. One possible, discussion was revolving around, the BCG vaccination. And if you look at the right side of this picture, then you see that about, the ones in blue, 7 of the 8 countries with the low mortality curve, they have BCG vaccination among others. However, there are some conflicted data around, so this is not a settled question, but you have to acknowledge that there is something. If you have had a lot of vaccinations throughout your life, and including BCG, then those countries reported overall low outcomes and low mortality. So that's about that. And then the public health response, before we go the second half of the presentation that will really relate to IBD. I'm sorry, so this is the possible response from the public health. We can do nothing. That's the no control effort, or like ease control effort. That is what was done actually in Sweden, and they were criticized quite heavily. However, the newer data don't look that bad. So on the long term, they might not be doing that bad at all. Then, a strong control, meaning full quarantine, social distancing. This is what quite a bit of the countries were embarking on. This is when we try to push down the curve, and then something in between. So this is what we could have done. And you see that there were the actual time span of the models that they were expecting, to have a control over the epidemic or pandemic. If you go further, this is the, once again, if you don't do anything, you have a very, very quick rise in the patient numbers. And, for quite a while, or in the early phase, your hospital system might be, of course, overloaded. And this is what we wanted to, in most of the countries, avoid. Once again, this was the curve that is representing more Sweden, who had at the early phase high patient numbers and high mortality. But now, once again, if you look at the total trends, then they are not doing that bad. And this is what most of the countries were, voting for. This is social, isolation, and then the quarantine, and really very strict measures about the movement of the population to flatten the curve and not to overload the healthcare system. So these are the possibilities, and this is what I told you. If you look at the average number of patients and the trend of the pandemic, if the R number, the number of cases infected by one patient infected, is more than 1, of course, then you have increasing numbers, and you want to have this below 1 so that you have control of the pandemic. What did we do? This is what you all know: physical and social distancing and quarantine, self-isolation. This is what we do, and this was actually quite successful, I guess, in Canada. And now the second half of the presentation will really concentrate around the IBD and what we do we know in COVID, and what do we have to do as IBD patients or doctors with the COVID. And I have some good news here. The early experience from Spain, and then I will show a publication from Italy and France. They show that actually the outcomes, if you look at the totality of the IBD patients, is not worse. Meaning that if you take 100 IBD patients, and now you don't care about whether the patients are active, what medications they are, and how long they have had the disease, and the general age of the IBD patients would be somewhat in line with the general population, then the outcome was not different. So to conclude, the IBD diagnosis itself didn't make the COVID risk or the COVID outcome risk worse for the IBD patients. That was one of the first publications from, once again, Spain in about late April, early May. And then my two friends, Laurent Perrin-Biroulet and Silvio Danese from Nancy, France, and then Milan, Italy, they published this paper, basically the same conclusion, that the IBD patients did not do worse in general with COVID, and then they didn't have more, negative outcomes. Of course, they have to a little bit look more in depth to the data, granular analysis. And that was also available because there is, maybe you have known that, if not, this is the SECURE IBD, an international website and project ongoing and collecting the COVID cases. You see, as of June 23rd, there is a weekly update. It's now more than 1,500 cases, about 450 hospitalizations, and luckily 50 deaths. So already, if you make the calculation, then this death toll is not higher than what you would expect in the general population, notwithstanding, of course, that the average age of the IBD patients is lower than the general population, so you don't want to have a 5% mortality in those patients. This is now 3% mortality, I would say, in line with the overall expectation and the age distribution of the patients. However, if you look again in depth, then you see one column is hospitalization, then second one is ICU, then ventilator use, then deaths, or all negative outcomes, and exactly echoing what was found in the general population. The curve starts to rise around 60 to 69. So you see that all the outcomes, hospitalization, again, ICU use, or death, they start to rise around 60, 69, 70, 79, 80 plus. So the same, the age is an important factor in IBD patients. This is what you see about the actually the medications here, and then the age distribution. And about the medications, you have a second most important table. Once again, the newer therapies, and this is why I highlight the biological therapies there, they didn't seem to worsen the outcome. What was really bad, that was active disease, the age, and the steroid use. Luckily, it seemed that the biological therapies or the newer biological therapies, not just the anti-TNFs, they didn't make such a tremendous difference with regards to the outcome. What you see there, that the oral parenteral steroid line, this is just below budesonide, the fourth line. This is what is actually showing the worst outcome. I don't blame steroids only. This, of course, highlights active or severely active patients. This is why you use the oral or IV steroids in those patients. So this means that this is, I guess, a label for, once again, severely active patients and the drug together, not necessarily just the steroids. If you look at comorbidities, same trend as without the IBD. So we can summarize, this is the SECURE IBD database, that in IBD, in general, the outcome and the risk for COVID is not worse than what we expect. The age, some medications, steroids especially, and active disease, and comorbidities, so the same factors, hypertension, diabetes, chronic lung, heart conditions, they are the important measures that we have to discuss with our patients when we discuss about the risk to have the COVID. And some, I would say, 4 or 5 weeks ago, the IOIBD, this is the International Organization of the IBD, which I happen to be part of. We had actually a roundtable and a guidance discussion and statements about the COVID and IBD. And you see exactly, it's echoing back with what I said. I will not read that through, but we identified that in general, the IBD population is not at higher risk. Notwithstanding, of course, active patients have higher risk. And then if you look at further down the line, then the patients with or without IBD do not have actually higher morbidity, once again, without active disease. So this is, the IOIBD statement, which is, echoing back also, like, the Canadian IBD and Gastroenterology Association at the moment. Same. AGA, USA, of course, that's important as well, especially if you look at other trends. Same exact statement. At baseline, the IBD patients appear to have actually a similar risk to the general population. And what changes that is disease activity and, again, the medications. And if you look at further recommendations from the Crohn's and Colitis Canada, then you see here, and this is what I was also part of, the next cartoon, that we try to develop a very easy image and risk scale, what we can use basically throughout our clinics. and discussing with patients about how they have to react to public health recommendations or self-isolation. And what you see here is basically age and medications and disease activity that make the rules, of course, besides the comorbidities. So this is what we use and what we offered, available also on the Crohn's and colitis website, and what we can offer to our patients, or the patient can actually evaluate themselves. To easier understand, what we have to do with the medications, and this is to stop, the suggestion to stop the medication. This is why the red is actually the good. That means that we don't have to stop those medications, and the green is actually bad, because that means that we have to stop the medication. Then you see again that most of the time the prednisone, the steroids, were identified as possible, importance. With regards to immunosuppressives, we had some discussion, because in general they have a higher risk for the viral or some of the viral outcomes, and this is why probably they were rated with more potential to worsen the outcome if the patient has an active COVID infection and needs hospital admission. That's what you see there. And also I have to acknowledge that there is no direct data besides the SECURE database that was still not available when we had this discussion, and when we had presented these results with the IBD with regards to the biological therapies. It's nice to see that the SECURE database, the SECURE IBD database, echoes back what we have found with regards to the risk of the biological therapies, meaning that just because the patient is taking biological therapy, we don't have to stop it in the COVID pandemic. If they are tested positive, of course, we will put them on a drug holiday for a certain time. And the question starts when the patient needs admission, either because of active, severely active IBD and or the active COVID as well, because then, of course, this will be a much more difficult discussion. So it's a very short recommendation with regards to the medications, avoiding high-dose corticosteroids if you can, combination therapy, and of course, because of the possibility of not needing an infusion center, subcutaneous therapies could be the preference if you start one. But if you have already started another medication that happened to be IV, we didn't change that just because of the route of admission. Once again, I've shown you the IBD, the international, then the Canadian, and now I show you the British recommendations, which are basically in line with what I have told before. Corticosteroids, immunosuppressives are on the top of that list, and the biologicals are discussed, but actually not regarded as high-risk medications. And then we have some recommendations about how to evaluate these patients. And this is, what they suggest whenever you have, of course, suggestive symptoms, and that is actually a question mark here, because about 2 to 5% of the patients, they have actually diarrhea. They don't have just cough or fever, but they can have diarrhea, simple diarrhea. And of course, that is what makes, the life of the IBD specialist difficult in this environment, because then, of course, there rises the question whether all the patients with diarrhea have to be tested for COVID if you suggest an IBD flare. However, if you discuss that this is a typical IBD flare with diarrhea, urgency, and blood, but not fever and chills, then you can just go with the possible IBD relapse and evaluation, so the lower part of the curve. However, if you have, of course, cough, especially productive cough, on top of, active abdominal pain and symptoms, then you go for the, upper part, and that would mean that you have to evaluate, whether the patient has COVID. So that's including the COVID testing, and what to do with the therapies is depending on how severe either the COVID symptoms or the IBD activity is. So this is the suggested evaluation by the American colleagues. That is actually also the one that we use today here in the everyday practice in Canada. There's just one single line, but I think it's an important one. If you actually happen to work around healthcare, then of course your risk is much higher. So you have to have a special evaluation. with regards to age, your risk, your comorbidities, plus the IBD if you work in the healthcare environment. So that's a little bit more complex. And I don't think, I will echo back that once again, but this is, just the, AGA recommendation with regards to what's happening in the IBD patients and the AGA summary. Before I stop, I really would like to acknowledge our partners, all the supporters, all the foundations, and also some of the pharmaceutical companies. Why I have the logo? Because they support our educational events directly. So this is why I like to actually say thank you for them as well. And I hope I could give some, new information to you on COVID in general, and especially with regards to the IBD. I stop here. And if you have any questions, please just send it in the chat box or just speak up and unmute yourself. Thank you.